I'm going to talk about our study, which compares the short and the long-term outcomes among survivors of ICU hospitalization with and without COVID-19 infection. Emerging data suggests that approximately half of the survivors of hospitalization for sepsis experience new symptoms, long-term disability, and worsening of comorbidities. Due to the disruption of normal care practices during the pandemic, it is unclear if survivors of COVID-19 will suffer the same long-lasting morbidity comparable to the other non-COVID-19 sepsis survivors. Our study aims to prospectively compare the short and the long-term sequelae of post-sepsis syndrome among survivors with and without COVID-19 infection. This is a prospective comparison including all mechanically ventilated adult patients with and without COVID-19 infection who were discharged alive from January to December 2020 from our institution. We obtained IRB approval and gathered baseline characteristics, which included BMI, pre-existing comorbidities, Apache score, Charleston Comorbidity Index, length of stay, including ICU stay, length of mechanical ventilation, amongst others. We used validated questionnaires such as the PHQ-9, the GAD-7, the PTSD score, and the Karnofsky's performance scale, as well as other questionnaires that focus on describing functional ability, changing consistency of diet, that would tell us about new onset dysphagia, all-cause rehospitalization, new cognitive impairment, that included memory, concentration loss, new onset attention deficit, speech disability, and decrease in executive function. We also included worsening of comorbidities, rehospitalization, new cardiovascular problems, ability to return to work, and evaluation of need for assistance in IADLs. All our eligible patients were contacted by phone by trained physicians. We separated the responders into 2 time periods for analysis, one group for less than 12 months in follow-up, and another group for more than 12 months. Out of the 221 patients who were discharged alive, 118 were included in the non-COVID group and 103 in the COVID-19 group. Out of the 58 responses in the non-COVID-19 cohort, 16 had expired, 5 refused participation, and 37 completed the follow-up survey. Out of the 58 responses in the COVID-19 group, 8 had expired, 4 refused participation, and 46 completed the survey. Our final response rate was 62%. These are the baseline characteristics for our study population. It was significantly higher for the COVID-19 group in the length of stay. The average vente was also significantly higher in the COVID-19 group. CHF, COPD, asthma had a higher incidence in the non-COVID-19 group, and the prior mental health diagnosis was also greater in the non-COVID-19 group. Now, to discuss the results. In the less than 12-month group, results were significant for decreased functional status, increased incidence of mental health conditions, and rehospitalizations in the COVID-negative group, and a higher incidence of dysphagia and less return to work in the COVID-19 group. In the more than 12 months, results were significant for decreased functional status in the COVID-19 group, higher incidence of aspiration pneumonia, rehospitalization, and new mental health diagnosis in the non-COVID-19 group, and there was also a higher worsening of medical conditions in the non-COVID group. The return to work after 12 months was significantly lower in the COVID-19 group.